I'm a pediatric surgeon at Rainbow Children's Hospital in Phoenix, Arizona, or at least I was, until I submitted my resignation 3 weeks ago. You can call me Dr. Sarah Martinez if you want. During my 21 years there, I've performed over 200 surgeries on children, correcting complex congenital heart defects, removing aggressive pediatric tumors, repairing devastating trauma injuries from car accidents and falls, reconstructing birth defects that threaten to steal a child's future before they'd even had a chance to dream, and operating on cases where a child's entire life hung by the thinnest thread imaginable. I thought I had seen every miracle and tragedy that pediatric medicine could offer. I've held the beating hearts of newborn babies in my palms while reconstructing their cardiac chambers, watching those tiny hearts continue to pump life through vessels no thicker than angel hair pasta. I've removed tumors the size of grapefruits from the abdomens of toddlers who giggled and asked for ice cream just hours after surgery. I've worked through Christmas nights, New Year's mornings, and countless family birthdays, missing my own children's school plays and soccer games to save other people's children whose parents waited in agony outside operating room doors, clutching coffee cups and prayer books, hoping against hope for just one more day, one more birthday, one more bedtime story with their little ones. In pediatric surgery, you learn quickly that children are both the most fragile and the most resilient patients you'll ever encounter. Their small bodies can be devastated by injuries that adults might survive, but they can also heal from trauma that would permanently disable a grown person. I've seen 3-year-olds bounce back from major organ reconstruction surgery and be running around the playground within weeks, while I've also seen teenagers succumb to complications from relatively minor procedures because their developing bodies couldn't handle the physiological stress. But what I'm about to tell you about is the one case that made me question everything I thought I knew about the human body, about healing, about death itself, and about what's medically possible in this universe we inhabit. It's the case of an 8-year-old girl named Sarah Blackwell, and what happened in Operating Room 5 on November 8, 2019, shouldn't have been possible according to every principle of surgery, human physiology, cellular biology, and medical science that I'd studied at Harvard Medical School, practiced during my residency at Boston Children's Hospital, perfected during my fellowship at Cincinnati Children's, and applied during more than 2 decades of pediatric surgical practice. What I witnessed that day didn't just defy medical explanation, it obliterated the very foundations of what we understand about life and death, about the absolute limits of human healing, about cellular regeneration, about the boundaries between possible and impossible, and about the profound mysteries that still exist within the human body that we medical professionals claim to understand so comprehensively. It was so impossible, so far beyond anything documented in peer-reviewed medical literature, taught in any medical school curriculum, or discussed at any surgical conference I'd ever attended, that it ultimately led me to leave pediatric surgery entirely and spend sleepless nights questioning whether everything I thought I knew about medicine, biology, and the nature of human life was merely scratching the surface of a much deeper, more mysterious truth about existence itself. Because once you've seen the medically impossible happen with your own eyes, once you've witnessed something that challenges not just your professional expertise, but the very core principles of scientific medicine, how do you go back to practicing surgery based on what you thought were unchangeable, immutable laws of biology, physics, and cellular function? How do you continue making life and death decisions based on medical textbooks when you've seen those textbooks proven catastrophically wrong? Let me tell you about Rainbow Children's Hospital first, because understanding the setting, the level of medical expertise available, and the sophisticated technology at our disposal is absolutely crucial to understanding why what happened to Sarah was so unprecedented, so impossible, and so fundamentally challenging to everything we thought we knew about pediatric medicine. Rainbow Children's Hospital is one of the premier pediatric medical centers in the southwestern United States, a 400-bed facility serving children from Arizona, New Mexico, Nevada, Utah, and parts of California, Colorado, and northern Mexico. We're not just a regional hospital treating routine pediatric cases, we're a destination medical center, a place where families travel thousands of miles to bring their children when other hospitals, other doctors, other medical teams have exhausted their options and delivered the devastating news that nothing more can be done. Our pediatric surgery department is consistently ranked among the top 5 in the nation by US News and World Report, and for good reason. We handle the most complex, challenging, and seemingly impossible cases that pediatric medicine encounters, conjoined twin separations that require months of planning and surgical teams of 20 specialists working in perfect coordination, in utero fetal surgeries performed on babies still in their mother's wombs, correcting life-threatening defects before birth, pediatric organ transplants involving hearts, livers, and kidneys, so small they could fit in the palm of your hand, reconstructive procedures so intricate and delicate that they require microscopic precision, and surgical techniques that push the absolute boundaries of what human hands can accomplish. The technology available to us represents the cutting edge of medical science. We have robotic surgical systems worth over $8 million that can perform procedures with precision measured in fractions of millimeters. Our imaging equipment can show real-time blood flow in vessels thinner than human hair, can track the electrical activity of individual heart cells, and can create three-dimensional models of a child's internal anatomy that allow us to practice complex surgeries in virtual reality before ever touching the actual patient. Our monitoring systems are so sophisticated that they track every heartbeat, every breath, every fluctuation in blood pressure, every change in brainwave activity, every shift in blood chemistry, and every alteration in organ function of our tiny patients. We can detect problems before they become life-threatening, we can predict complications before they manifest clinically, and we can intervene with surgical precision that would have been considered science fiction just 2 decades ago. The surgical suites themselves are marvels of medical engineering. Operating Room 5, where Zara's surgery took place, is equipped with laminar airflow systems that create completely sterile environments, surgical lights that can illuminate tissue with the intensity and precision of microscopic examination, and communication systems that allow our surgical teams to coordinate with specialists around the world during complex procedures. I didn't arrive at Rainbow Children's as a rookie surgeon learning the basics of pediatric care. My path to becoming one of the country's leading pediatric surgeons began during my undergraduate years at Stanford University, where I majored in biochemistry with a focus on cellular regeneration and tissue repair mechanisms. I graduated summa cum laude and was accepted into Harvard Medical School, where I spent 4 years studying not just surgical techniques, but the fundamental biological processes that govern how the human body heals, adapts, and responds to medical intervention. During medical school, I became fascinated by pediatric medicine because children's bodies represent the pinnacle of human healing potential. Unlike adults, whose cellular repair mechanisms have slowed with age, children possess remarkable regenerative capabilities that allow them to recover from injuries and surgeries with speed and completeness that often amazes even experienced medical professionals. After graduating from Harvard, I completed my general surgery residency at Massachusetts General Hospital, one of the most demanding and prestigious surgical training programs in the country. During those 5 years, I performed over 200 surgeries under the supervision of some of the world's most skilled surgeons, learning not just the technical aspects of surgical procedures, but the critical thinking, decision-making, and crisis management skills that separate competent surgeons from exceptional ones. But general surgery, even at the highest level, didn't satisfy my desire to make the most meaningful possible impact on human life. I wanted to work with patients who had decades of potential life ahead of them, who could benefit from surgical intervention, not just for a few years, but for entire lifetimes of possibility. That's why I applied for and was accepted into the Pediatric Surgery Fellowship at Boston Children's Hospital, widely considered the most competitive and comprehensive pediatric surgical training program in the world. The fellowship was 3 years of the most intensive medical training imaginable. I worked 18-hour days, took call every third night, and performed surgeries on children ranging from premature newborns, weighing less than 2 pounds, to teenagers with complex medical conditions that required surgical solutions no adult surgeon would ever encounter. I learned to operate with the delicacy required for babies whose entire cardiovascular systems could fit in a teacup, and I developed the mental fortitude necessary to remain calm and precise when a child's life depended on surgical decisions made in seconds under enormous pressure. During my fellowship, I was privileged to work with Dr. Margaret Chen, one of the pioneering figures in pediatric cardiac surgery, who taught me that successful pediatric surgery requires not just technical skill, but an almost supernatural level of patience, precision, and emotional resilience. When you operate on a child, Dr. Chen told me during my second year of fellowship, you're not just repairing their body, you're protecting their future, their dreams, their potential to experience all the joys and challenges that life offers. Every incision you make, every suture you place, every decision you make in that operating room will affect not just that child, but their parents, their siblings, their future families, and potentially generations of people who will exist because you gave that child the chance to grow up and live. From an anesthesiology standpoint, laparoscopic gallbladder surgery is considered a routine, low-risk procedure. Patients are typically put under general anesthesia for about 60 to 90 minutes, while surgeons perform the operation. The anesthetic management is straightforward: standard induction medications, routine maintenance of unconsciousness during the procedure, and predictable emergence from anesthesia afterward. Most patients go home the same day or after one night in the hospital. It's the kind of surgery that anesthesiologists handle almost automatically, using established protocols and standard medication dosages that have been refined over decades of successful procedures. Isabella had no significant medical history that would complicate her anesthesia management. She was young, healthy, physically active, with no previous surgeries or adverse reactions to medications. She didn't smoke, used alcohol only occasionally, and wasn't taking any prescription medications that would interact with anesthetic drugs. Her preoperative evaluation was completely normal, had excellent heart and lung function, normal blood work, including liver and kidney function tests, no concerning factors that would make anesthesia risky or unpredictable. She was exactly the kind of patient that should have had a completely uneventful anesthetic experience, with no complications or unusual responses to the medications we would use. During our preoperative consultation, the evening before her surgery, Isabella was understandably nervous about being put under general anesthesia. Like many patients, she had heard horror stories about people who woke up during surgery, who experienced anesthesia awareness, or who had severe reactions to anesthetic drugs. She had done what many patients do in the internet age, researched her procedure online, and come across websites and forums discussing rare but frightening anesthesia complications. She asked me the questions I'd heard thousands of times before. Will I definitely be unconscious the whole time? Is there any chance I'll wake up or feel anything during the operation? How do you know for sure that I won't be aware of what's happening to me? I gave her the same thorough and reassuring explanations I had provided to thousands of other patients over the years. I explained our sophisticated monitoring systems that track brain activity throughout surgery, ensuring that patients remain at exactly the right level of unconsciousness. I described our backup protocols, our multiple redundant safety systems, our decades of successful anesthesia management. I told her about the specific drugs we use to ensure complete unconsciousness. 9. Sage, how propofol works to eliminate awareness within seconds. How our volatile anesthetics maintain that unconscious state throughout surgery. How our monitoring equipment provides continuous feedback about her level of anesthesia. I assured her that modern anesthesia is extraordinarily safe and reliable, that the chances of her experiencing any awareness during surgery were virtually zero. But Isabella's concerns went beyond typical pre-surgical anxiety. She looked directly into my eyes with an intensity that made me pay closer attention to what she was saying. "Dr. Thompson," she said, "I need to tell you something that might sound strange, but I've had unusual experiences with consciousness my whole life. I have incredibly vivid dreams where I sometimes can't tell if I'm asleep or awake. Sometimes I dream about things that haven't happened yet, and then they occur exactly as I dreamed them, days or weeks later. My grandmother used to say that the women in our family were sensitive to things that other people couldn't perceive, that we could sense things beyond normal awareness." She paused, clearly uncomfortable with sharing something so personal with a doctor she had just met. "I know it probably sounds silly or superstitious to you, but I'm genuinely worried that I might somehow be different from other patients, that the anesthesia might not work the same way on me that it does on everyone else. What if my brain doesn't respond to the medications the way it's supposed to? What if I'm somehow aware during the surgery, even though your monitors say I'm unconscious?" I had heard similar concerns from patients before, usually related to family stories about unusual reactions to medications, or deeply held beliefs about having some kind of special sensitivity to medical treatments. In my experience, these concerns were almost always unfounded. Anesthesia works on basic neurological and physiological principles that are fundamentally the same for virtually everyone. While there can be minor variations in how quickly people metabolize certain drugs or how sensitive they are to specific medications, the core mechanisms of consciousness and unconsciousness are consistent across all patients, regardless of their family history, personal beliefs, or subjective experiences with dreams and awareness. "Isabella," I told her gently but confidently, "I completely understand your concerns, and it's absolutely normal to be nervous about anesthesia, especially when you're someone who pays close attention to your consciousness and dream states. But I want you to know that what you're describing, vivid dreams, feelings of unusual sensitivity, even experiences that seem prophetic, won't affect how anesthesia works on your brain. The medications we use target specific neurotransmitter receptors and neural pathways that control consciousness at the most basic biological level. Regardless of your dreams, your family's beliefs about sensitivity, or any unusual experiences you've had with awareness, the anesthesia will work exactly the same way it does for every other patient." I explained to her how anesthetic drugs function at the molecular level, how they bind to GABA receptors in the brain, and essentially flood the nervous system with inhibitory signals that shut down conscious thought. I described how we monitor brain wave activity throughout surgery using processed EEG technology that shows us exactly how deeply anesthetized patients are at every moment. I assured her that if there were any unusual responses to the medications, if her brain didn't respond typically to the anesthetic drugs, our monitoring equipment would detect those differences immediately and allow us to adjust our approach accordingly. Isabella nodded as I spoke, but I could see that my scientific explanations didn't completely ease her anxiety. There was something in her expression, a kind of resigned acceptance, mixed with persistent, deep-seated worry, that stayed with me after our consultation ended. She seemed to be someone who had learned to live with experiences that others couldn't understand or validate, and who had developed a kind of protective skepticism about assurances from authority figures who dismissed her concerns as imaginary or irrelevant. "I appreciate everything you've explained to me, Dr. Thompson," she said as our consultation concluded. "I'm sure you're right, that the anesthesia will work normally, but I want you to know that if something unusual does happen, if I do experience anything during the surgery that I shouldn't be experiencing, it won't be because I'm anxious or because I have an overactive imagination. I've learned to trust my instincts about these things, even when other people think I'm being unrealistic." I assured her once more that modern anesthesia monitoring would prevent any possibility of awareness during her surgery, but something about her calm certainty, not hysteria or panic, but a quiet, resigned expectation that something might go wrong, left me slightly unsettled. However, I dismissed her concerns as typical pre-surgical anxiety combined with strongly held personal beliefs about sensitivity and awareness. I had no reason to expect that this case would be any different from the countless other gallbladder surgeries I had managed throughout my career. The night before Isabella's surgery, I followed my usual routine for reviewing upcoming cases. I studied her medical records one final time, confirmed the anesthesia plan with Dr. Sarah Mitchell, the surgeon who would be performing the laparoscopic cholecystectomy, and prepared all the medications and equipment we would need for her procedure. Everything was completely standard and straightforward, exactly what I had done thousands of times before for similar patients undergoing similar procedures. I calculated drug dosages based on her weight and medical history, verified that all monitoring equipment was functioning properly, and reviewed emergency protocols in case any unexpected complications arose during surgery. Isabella was scheduled as the first case of the day in operating room 7, with surgery planned to begin at 7:30 a.m. I arrived at the hospital at 6 a.m., as was my routine, to review the day's cases and ensure that all equipment and medications were properly prepared. The anesthesia cart was stocked with standard drugs: propofol for induction, sevoflurane for maintenance of anesthesia, fentanyl for pain control, vicuronium for muscle relaxation. The monitoring equipment had been tested and calibrated: EKG for heart rhythm, pulse oximetry for oxygen levels, capnography for breathing, processed EEG for brain activity monitoring, and automated blood pressure measurement. Everything was exactly as it should be for a routine surgical case. What I didn't know was that Isabella Reeves would become the patient who would fundamentally change my understanding of consciousness, anesthesia, and the nature of awareness during surgery. What happened in operating room 7 that Tuesday morning would challenge everything I thought I knew about what it means to be unconscious under general anesthesia, and would reveal possibilities about surgical awareness that I never could have imagined based on my training and experience. The case I'm about to describe didn't just end my career in anesthesiology, it shattered my confidence in the fundamental assumptions that underpin our entire approach to managing consciousness during surgery. What Isabella experienced under anesthesia, and what I witnessed as her anesthesiologist, raises questions that I still can't answer and suggests terrifying possibilities about surgical consciousness that keep me awake at night, wondering about every patient I've ever anesthetized during my 18 years of practice. What I discovered that morning suggests that everything we think we know about anesthesia and surgical unconsciousness might be incomplete at best and completely wrong at worst. It raises the possibility that the patients we put to sleep for surgery might be experiencing far more than we ever imagined possible, and that our sophisticated monitoring equipment might be missing forms of awareness that exist beyond our current understanding of consciousness and the human brain. But before I tell you exactly what happened to Isabella during her surgery and how it changed everything I believed about anesthesia, you need to understand the confidence I had in my abilities, the trust I placed in our monitoring systems, and the absolute certainty I felt that patients under my care were completely protected from awareness during surgery. Because what occurred in operating room 7 that November morning would challenge all of those assumptions and force me to confront the possibility that I might have been wrong about consciousness and anesthesia throughout my entire career. At 7:30 a.m. on November 14, 2023, Isabella was wheeled into operating room 7. The morning routine proceeded exactly as I had planned. I reviewed her chart one final time, confirmed the surgical plan with Dr. Mitchell, and began the anesthesia induction process. Isabella looked up at me with those same intense eyes from our consultation the night before, and I gave her a reassuring smile. "Just breathe normally, Isabella. You'll be asleep in just a few seconds, and when you wake up, this will all be over." I administered the propofol through her IV line, watching her consciousness fade within seconds as her eyes fluttered closed and her body relaxed completely. Her vital signs were absolutely perfect. Heart rate steady at 65 beats per minute. Blood pressure reading 118/70 seconds. Oxygen saturation at 100%. The processed EEG monitor showed exactly the brainwave patterns I wanted to see. Deep anesthetic levels, indicating profound unconsciousness. I intubated her without any complications, connected her to the ventilator, and administered the muscle relaxant that would keep her completely paralyzed throughout the procedure. Dr. Mitchell scrubbed in and began the laparoscopic cholecystectomy. She made the first small incision, inserted the trocar ports, and inflated Isabella's abdomen with carbon dioxide to create space for the surgical instruments. Everything was proceeding exactly as it should for a routine gallbladder removal. I monitored Isabella's anesthesia levels continuously, adjusting the sevoflurane concentration to maintain perfect surgical conditions. Her vital signs remained stable. Her EEG showed consistent deep anesthesia patterns, and she exhibited no physical responses to the surgical manipulation. 45 minutes into the surgery, as Dr. Mitchell was carefully dissecting around the gallbladder to identify the critical structures, something unprecedented and impossible happened. Isabella's eyes suddenly opened, and she turned her head to look directly at me with complete, unmistakable awareness. But here's what made this medically impossible. Every single monitor in that operating room showed that she was still deeply anesthetized. Her processed EEG continued to display the flat, suppressed brain wave patterns that indicated profound unconsciousness. Her heart rate remained steady at 68 beats per minute, showing no signs of stress or awareness. Her blood pressure hadn't changed. The capnography showed regular, controlled ventilation. According to every piece of monitoring equipment we had, Isabella was exactly as unconscious as she should be for major abdominal surgery. Yet she was clearly, undeniably, awake and aware. "Dr. Thompson," she said clearly, and I could hear her voice as distinctly as if she were speaking normally in conversation. But she was intubated. There was a breathing tube down her throat, connected to the ventilator. Her vocal cords were not functioning. Her lips weren't moving. Her facial muscles were completely paralyzed by the vacuronium. She could not physically speak, yet I was hearing her voice with perfect clarity. "I can see everything that's happening," Isabella continued, her voice calm and matter-of-fact in my mind. "I can see you checking the monitors, trying to figure out what's wrong. I can see Dr. Mitchell working on my gallbladder. Yes, she's being very careful around what looks like an artery. But Marcus, I can also see things that aren't in this room." I frantically checked every monitor, every connection, every piece of equipment. The EEG was functioning perfectly, showing the characteristic patterns of deep general anesthesia. The Bella's monitor, which specifically measures consciousness levels, read 23, indicating profound unconsciousness, where patients should have no awareness whatsoever. This was medically impossible. Everything I had learned in medical school, residency training, and 18 years of practice told me that what I was witnessing could not be happening. "There's a man standing right behind you," Isabella said, and I felt a chill run down my spine. "He's wearing a navy uniform, dress blues with gold buttons. He's young, maybe in his 20s, with dark hair like yours. He says his name is Robert, and that he's been waiting a very long time to give you a message about the accident." My blood ran completely cold. My brother Robert had died in a naval training accident 15 years ago, when he was just 24 years old. I had never mentioned Robert to anyone at Mercy General Hospital. No one on the surgical team knew I had a brother. much less that he had died in military service. There was no way Isabella could have known anything about Robert's existence, let alone details about his appearance or his death. "He's telling me about the night before he died," Isabella continued, her mental voice clear and calm even as her body remained completely motionless under anesthesia. "You were at the hospital working on a trauma case, a motorcycle accident victim who needed emergency brain surgery. Robert called you around midnight because he was worried about some equipment problems they were having during training exercises. He wanted to talk to you about whether he should report the safety concerns to his commanding officer." Every word she spoke was accurate. That phone call had haunted me for 15 years. Robert had been concerned about malfunctioning diving equipment that the Navy was still requiring trainees to use. He wanted advice about whether to risk his military career by formally reporting the safety violations. I was exhausted from a 12-hour surgery and told him we'd discuss it when I got home. We never had that conversation. The equipment failed the next day during a training dive, and Robert drowned. "Marcus," Isabella's voice continued, "Robert says the accident wasn't your fault. She says you couldn't have known that the equipment would fail so catastrophically, and that even if you had stayed on the phone longer that night, it wouldn't have changed what happened. He wants you to stop carrying that guilt. He says it's been destroying you for years, and it's time to let it go." For the next 20 minutes, as Dr. Mitchell continued the surgery, completely unaware of what I was experiencing, Isabella relayed messages that could only have come from Robert himself. She described specific childhood memories we had shared, conversations from our teenage years, private jokes, and moments that existed only between my brother and me. She spoke about our parents, about family vacations, about Robert's dreams of becoming a naval officer, about details that no living person besides me could possibly know. But it wasn't just about Robert. Isabella began describing things about other people in the operating room that she had no way of knowing. She told me about Dr. Mitchell's recent divorce, including specific details about custody arrangements for her children that Mitchell had shared only with her closest friends. She described the scrub nurse's father's battle with pancreatic cancer, mentioning his exact diagnosis and treatment plan that the nurse had never discussed at work. She revealed information about the anesthesia technician's financial struggles, his son's drug addiction, personal details that he kept completely private from his professional life. All of this while remaining completely unconscious according to every monitor we had. When the surgery concluded and I began bringing Isabella back to consciousness, reversing the anesthesia and removing her breathing tube, she awakened exactly as thousands of my previous patients had, gradually, peacefully, with no apparent complications. But as soon as she was fully alert in the recovery room, Isabella looked at me with those same intense eyes and said, "Dr. Thompson, I need you to know that I remember everything that happened during my surgery." She proceeded to describe not just our impossible conversation, but details about the entire surgical procedure that she should have been unconscious for. She knew exactly when Dr. Mitchell had encountered difficulty identifying the cystic artery. She described the moment when one of the trocar ports had been repositioned. She even mentioned when the surgical technician had dropped an instrument and had to get a replacement from the sterile supply. Most disturbing of all, Isabella told me about things she had observed happening in other parts of the hospital while she was under anesthesia: a code blue emergency in the ICU, a difficult delivery in the obstetrics ward, conversations taking place at the nurse's station 3 floors above our operating room. When I discreetly confirmed these details later, every single thing she had described had actually occurred exactly as she said, at the precise time she mentioned. 3 weeks later, I submitted my resignation from Mercy General Hospital. How could I continue practicing anesthesiology when I now knew that consciousness might exist in ways that our most sophisticated monitoring equipment cannot measure or detect? How many of the thousands of patients I had anesthetized over 18 years had experienced some level of awareness, while I believed they were safely and completely unconscious? Isabella's case changed everything I thought I knew about consciousness, anesthesia, and the nature of human awareness. awareness. Some mysteries in medicine don't have answers, they just change everything we thought we knew about what it means to be human and what might exist beyond our current understanding of life and death.